Today's learning module is on palliative care and end-of-life care. Edward Livingston Trudeau said, "The art of medicine is to cure sometimes, to relieve often, and to comfort always." Prior to our learning module, we're going to do a pre-test assessment, which you'll complete as well at the end. Palliative care is care for those with life-limiting illnesses and their caretakers with focus on symptom control and quality of life. A, true. B, false. Hospice care provides comprehensive comfort care, as well as support for the family while curative treatments are continued. A, true. B, false. Palliative care and hospice care are the same. A, true. B, false. Accepting hospice care means stopping all medical treatment. A, true. B, false. Palliative and hospice involves a team of both medical and non-medical providers. A, true. B, false. Hospice is covered by nearly all insurances. A, true. B, false. First, we'll go over some statistics in regards to hospice and palliative care. By 2030, the older population of the United States will be nearly 1 billion. That is 12% of the projected total world population. And by 2050, 1.6 billion of the total population will be 65 and older. By 2030, the baby boomer generation will be older than 65. This will expand the size of the older population so that 1 in every 5 residents will be of retirement age. If we look at this infographic, we can see that our population is aging quickly. The number of adults over 65 will far exceed the number of children under 18. This shows that the need for palliative and hospice care will increase. This infographic shows the difference between 1960 and projected how 2060 will look in terms of the demographics of our population. It is no longer that we have a small aging population. Our aging population is growing, and we will need to address the palliative issues in hospice care. Older adults are disproportionately affected by chronic illnesses such as diabetes, arthritis, and heart disease. Approximately 85% of older adults have at least one chronic health condition, and 60% have at least 2 chronic health conditions. In 2017, it was estimated that over 56 million people were in need of palliative care. The majority of them live in low and middle income countries. Worldwide, only about 14% of people who needed palliative care were receiving it. The aging of the world's population, increases in cancer and other non-communicable diseases, and the recent emergence of COVID-19, the need for palliative care is ever increasing. By 2060, the need for palliative care and end-of-life care is expected to double. If we look at these estimates based on age, looking at this pie chart, patients that are 50 and above, 70% of them required palliative care or are in need of it. That number will grow significantly as our population grows. What is palliative care? How would you define it? The World Health Organization defines it as palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification, impeccable assessment, and treatment of pain and other problems, physical, psychosocial, and spiritual. How is this relevant? Currently, contemporary medicine has come to focus on disease-specific treatments rather than the needs of the whole person and their family. This can result in unnecessary suffering, burdensome and costly interventions, untreated pain and symptoms, lengthy hospitalizations, and unnecessary emergency room visits. Also, overwhelmed caregivers and clinician burnout. The system as is results in poor quality of life and high healthcare cost. We need to refocus our care goals. The goal of palliative care is to improve the quality of life for both the patient and the family. Palliative care focuses on the needs of the patient and not on the patient's prognosis, thus providing quality, not only quantity. It aims to decrease the overall burden that medical conditions impart on the patient and caregiver by comprehensively addressing the physical, emotional, and spiritual suffering. The benefits of palliative care. It improves communication, provides caregiver support, offers psychological and spiritual care, develops a support system to help the patient live as fully as possible, improves patient and caregiver satisfaction with care, improves overall quality of care, and not only relieves pain and suffering, but it attempts to prevent it. As geriatricians, we have to think of what our patients want and what matters to them. Palliative care provides this. End-of-life care or hospice care. What is it? Hospice care and palliative care both provide comprehensive comfort care as well as support for the family. End-of-life care can be implemented once curative treatments are no longer pursued. Hospice is provided for a person with a terminal illness whose doctor believes that they have 6 months or less to live if the illness runs its natural course. Hospice care, unlike palliative care, is covered by nearly all insurances, including Medicare and Medicaid. Here's a Venn diagram illustrating how palliative care and hospice care differ and are the same. They treat life-threatening illnesses. They focus on symptom control, optimizing comfort and quality of life. They provide psychosocial support, spiritual support, and take into account patients' goals of care. How they differ. Hospice care can be implemented once a patient is deemed to have 6 months of life or less, if their disease is to run its natural course, and also if they have opted out of curative treatment. Palliative care, on the other hand, does not require this and can be used at any stage of disease. Palliative care and end-of-life care, according to the National Hospice and Palliative Care Organization, showed that 53.8% of Medicare hospice patients received comfort care for 30 days or less in 2018. Of these patients, more than a quarter received hospice care for only a week or less. Population data suggests that hospice care is not sought out until very late in the process of dying. Accepting the progression of disease as a continuum and incorporating palliative care from the onset can ease the transition needed for appropriate end-of-life care. Now, if you see these two models, the traditional palliative care model shows that a patient will pursue lifelong, prolonging, or curative treatment with no palliative input or care until they are at the end of their disease progression, and that is when the support of palliative care and end-of-life care is implemented. The newer model encourages incorporation early on, once we have these chronic treatments, chronic illnesses, and can improve overall quality of life and refocus on patients' goals of care. Who needs palliative care? Life-limiting illnesses such as cancer, end-stage organ failure, and progressive neurological conditions, including dementia. We note that palliative care and cancer are often associated, and these patients seem to receive earlier interventions for palliative care than other patients with chronic diseases. One study evaluating palliative care received by a sample of adults who died of cancer or terminal non-cancer illnesses in the last year of life found palliative care was more likely to be initiated earlier in cancer patients. Palliative care was delivered across multiple care settings in patients with cancer than those with organ failure or dementia. Patients with cancer were more likely to receive palliative care more frequently and also using a consultative or specialist model versus a generalist model. What does this tell us? This tells us that there is a large gap in care. Patients with end organ disease and other chronic diseases such as dementia may not be receiving the appropriate support that they should be from palliative care. If we look at the top leading causes of death in 2018 in the United States, heart disease is above cancer. This end organ failure is something that needs palliative care. And we need to raise awareness of its ability to support our patients. This graphic shows how cancer's disease progresses in the green line. You can see it is a steady progression and an abrupt drop-off with cancer, as opposed to end organ failure and dementia, which is more progressive. Both situations would benefit from palliative care and end-of-life care. What affects this? Prognosis. And how do we define that? Prognosis is defined as a thorough appraisal of diagnosis, comorbidities, and pathology. Things to consider: the various treatment options based on the clinical situation, the preference of informed patients or proxies. How does it prognosis impact patients and their families? Palliative care teams frequently are able to realign goals of care based on prognostic information. Prognostication can impact the decisions of families and patients make about the time shared together, estate management, funeral planning, and other practical issues. One study, called the Support Study to understand prognosis and preference for outcomes and risks of treatment, used computer-generated algorithm to prognosticate. And it showed that patients that received prognosis of surviving 2 months of 40% or less increased their advanced directive discussions, and also were more likely to opt out of CPR. Another survey of American internists regarding prognosis noted that many physicians avoided prognosticating, generally waiting to be asked than volunteering a prediction. The conditional nature of a formulated prognosis means, unlike the diagnosis, it needs to be reformulated at regular intervals. This dynamic nature of prognosis can help balance the inherent uncertainty. As clinicians, we avoid prognosticating if we are able to incorporate it into our care, incorporate palliative care into our care, then it becomes a more dynamic model in which we can incorporate the patient's needs and the family's concerns. Prognosis. How do we assess prognosis? Functional capacity has been shown to have significant bearing on prognosis. Tools that we use in assessment of functional capacity are the Kamensky Performance Status, Palliative Performance Scale, CAT's Activity of Daily Living, Edmonton Functional Assessment Tool, Time Up and Go, and 6-Minute Walk Test. These tools and other scales have shown that functional capacity has impacts on a patient's prognosis and can be used in their assessment.
Hi, hello to all my colleagues. My name is Saima Rashid. I'm one of the geriatric fellow working at SUNY Downstate, and today I'll continue with the presentation with my colleagues. So, starting from the importance of communication with our patient. Effective communication between the palliative team, patient, and the caregiver is vital to facilitate care and enhances experience and satisfaction with the care of a patient. Understanding of patients' preferences medically, emotionally, and spiritually, providing opportunity for them to collaborate in their care. Development of the team and the patient's relationship, patient's ability to plan for the future and set goals for the future care. Spikes is a strategy for delivering bad news. S is setting up the interview. P is like assessing the patient's perception, obtaining the patient's invitations, giving knowledge and information to the patient, and addressing the patient's emotions with empathic responses, and then strategies and summary. What are advanced directives? Advanced care planning enables patients to take control of their future health care and treatment when they are not able to communicate their wishes. Communicating these discussions early and throughout providing care for the patient can ensure that the patient's wishes are respected. A high percentage of people are unable to make decisions as they approach the end of their life, and they often rely on their family and healthcare team to make these complex care decisions on their behalf. What are advanced directives? Advanced directives allows patients' treatment preferences to be effectively documented, and there are different types of advanced directives. Number one, living will, then a medical power of attorney, and DNR order. Living will. It is a written legal document that outlines medical treatments a patient would or would not want to be used to sustain their lives, as well as preferences for other medical decisions, such as cardiopulmonary resuscitations, mechanical ventilation, tube feeding, dialysis, use of antibiotics or antiviral medications versus comfort care, and then organ and tissue donations. Medical power of attorney is an advanced directives where a patient can name a person to make decisions for them when they are unable to do so. In some states, these directives may also be called a durable power of attorney for healthcare or healthcare proxy. DNR, do not resuscitate order. It is one of the component of living will. However, often it may be the single aspect that is decided, reassessed each time a patient is in an acute care setting. Some states allow specific orders that express patients who specifically prefer to not be intubated as well as, which is known as DNI, do not intubate. MOLST form is a medical order for life sustaining treatment. The MOLST serves as a single document that contain a patient's goals and preferences regarding resuscitation instructions when a patient has no pulse or is not breathing. Instructions for intubation, mechanical ventilation when a patient has pulse and the patient is breathing. Future hospitalization and transfer, artificially administering fluids, nutrition, antibiotics use, and instructions on treatment which are not listed. Under state law, the MOS form is only authorized form in New York State for documenting both non-hospital DNR and do not intubate DNI orders. In addition, the form is beneficial to the patients and providers as it provides specific orders and is recognized and used in a variety of healthcare settings. Coming to the goals of care discussion. Goals of care discussion can outline a patient's wishes in regards to their advanced directives, healthcare proxy, DNR status. This discussion is not to be limited to the goals of end of life care, but should clarify how a patient wishes to live and what to do during their course of care. It is evolving discussion and should be initiated early in outlining the treatment for life-limiting illnesses. It also allows for an individual's treatment to align with their preferences in regarding to how the patient would like to live. Goals of care discussion remap a stepwise approach. Reframe perception and understanding of the clinical status and prognosis. Expect emotions when conflict about the decisions arises between clinicians and patient or their family. Addressing the underlying emotions is much more likely to lead to resolutions. Map out the future. It is to identifying the patient's goals prior to recommending any treatment and align with values. By aligning with the patient's or their caregiver's values, the clinician demonstrates that the patient and the caregiver has been heard. Plan treatment with that match the values of the patient. Next, one should transition from the patient's and the caregiver's stated values to specific treatments or care plan that will help accomplish agreed upon goals. Communicating for preparation. Communicating palliative care goals with a concurrent treatment allows for the development of dynamic and a unique plan that will lead to gentler transition into the end of life care once the time arrives. Decisions on advanced directives and goals of care are best decided when the patient is able to make informed, conscious decisions that caregiver can continue to fulfill. End of life care. It is a medications review, elimination of unnecessary medication, then the PRN as needed medications with appropriate parameters. Essential interventions, limiting blood draws or invasive interventions. Communications when or for what the family wants to be contacted. Spiritual culture rituals awareness. End of life symptoms. Symptom management and minimizing the resulting suffering is cornerstone for the quality palliative and end of life care. Patient with end life limiting disease often will need management of their pain, their dyspnea, their poor appetite, depression, constipation, and agitation. Somatic pain arises from musculoskeletal system and is described as aching, stabbing, or throbbing. Treatment is usually NSAIDs, non-opioid drugs. Visceral pain arises from internal organs and described as cramping, pressure, dull, or squeezing pain. Treat with anticholinergic meds or opioids. Then there is a neuropathic pain arises from the nerves and nervous system. It is described as tingling, burning, or shooting pain. These are usually treated with anticonvulsants. This is a tool that is used for the pain assessment. It's universal pain assessment tools from 0 to 10, 0 being no pain and 10 being the worst pain possible. And then there are we have a verbal descriptor scale, we have a Wong Baker facial grimace scale, and an activity tolerance scale. Pain assessment in advanced dementia scale. This is PAINAD. This is used. This is scale. First, we look at the behavior of the patient, and first, like look at the breathing. Assess how the patient is breathing. Is independent of vocalization. um, if the patient is breathing normally, we will give a 0 point. And then if a patient is occasionally labored breathing, a short period of hyperventilation, that will give him 1 point. And then noisy labored breathing, long period of hyperventilation, or Chine-Stokes respirations, 2 points. Looking at the vocalization, if the patient negative vocalization, none, zero. Occasional moans or groans, low level speech with a negative or a disapproving quality, 1 point, and repeated troubled calling out, loud moaning, groaning, and crying, 2 points. Looking at the facial expression, if the patient is smiling or he's inexpressive, you give 0 points. 1 point for a sad, frightened, and frown look, and 2 points for the facial grimacing. Assessing the body language, if the patient's body language is relaxed, 0 points. Patient looks tense, distressed, pacing, and fidgeting, 1 point. And if the patient looks rigid, fists are clenched, knees pulled up, pulling or pushing away, streaking out, 2 points. Consolability. If there is no need to console, 0 point. Distracted or reassured by voice or touch, 1 point. Unable to console, distract, or reassure, 2 points. This can be used in the patient who have again dementia and they're unable to um, appropriately let the provider know how much pain they are in. Scoring is a total score ranges from 0 to 10 points. A possible interpretation of the score is 1 to 3 will be mild pain, 4 to 6 moderate pain, and 7 to 10 severe pain. These ranges are based on the standard of 0 to 10 scales of pain but have not been sustained in the literature for this tool. What is dyspnea? This is a subjective breathlessness. It can be triggered by primary lung disease, but it can also be related to other organ diseases. It can also be related to pain, discomfort, and anxiety. Subjective scale measurement can be used to trend symptoms or track triggers. Objective measures are to look at patient's respiratory rate and the patient's oxygen saturation. So, how do we treat patient with dyspnea? We gave a patient oxygen therapy, ambient air therapy, cooling fan, opioids, bronchodilators, corticosteroids, and diuretics when clinically indicated. Poor appetite is another symptoms. Loss of appetite can be quite distressing for caregivers and family and friends. In many cultures, food is associated with caring and comfort. In late stages of illness, caregivers can often voice concern as a patient deteriorates that they are declining because of lack of food. Reassuring and educating should be given by patient's healthcare team explaining it is expected in the course of death. Feeding via enteral feeding does not clearly prolong life, improve quality of life, or decrease aspiration in terminal patient. High calorie supplements and pharmacological appetite stimulants are not recommended and they come with their own side effects. Poor appetite causes multifactorial. It could be side effect of the treatment, side effect of the medications related to patient's nausea, constipation, symptoms related to depression, fatigue, dry mouth, progression of the disease, and associated lack of hunger as eating becomes burdensome. Depression is another concerns to be taken into consideration. Studies have shown that depression is an independent predictor of mortality in patients with a coronary heart disease. Meta analysis studies of the cancer patients suggest depression may be utilized similarly to the predicted mortality. In this review, those with depressive symptoms had a 26% greater mortality, and those diagnosed with a major depressive disorder had a 39% higher mortality, an effect that was independent of other risk factors. Support and assessment from psychiatry and psychology members of the palliative care team may provide vital interventions for coping and reconciling challenging process of dying. Depression can be treated with CBT, cognitive behavior therapy. It could also be treated with a pharmacological treatment, which could be psychostimulants because of their rapid onset of actions, are useful agents, and are generally well tolerated. SSRIs, selective serotonin reuptake inhibitors, and tricyclic antidepressants may also be used. And other symptoms, constipation. It may present as an agitation. So causes could be the patient is dehydrated, patient is immobile, patient sometimes are on opioid for a pain control leading to constipation. Objective evaluation, look at the patient, have a physical examination, especially abdominal and rectal exam. We could also do an x-ray of the abdomen. Treatment, it could be laxatives, enema, and bowel stimulants. Agitations. Often agitation arises due to untreated issues causing the discomfort that we have mentioned. Careful evaluation and examination may reveal the underlying cause. End of life is also associated with terminal agitation and delirium, in which no clear classes of the medications can be shown to be a preferred choice. However, benzodiazepines and phenothiazines have some effect. Diagnosing dying. Clinicians are not often well trained or comfortable in diagnosing dying. Studies have shown that patients with a life limiting diagnosis prefer to be informed of such information to cope with their circumstances. One study in the UK showed 49% of the patients were recognized as dying 24 hours or less before the death. 17% between 24 to 36 hours before death, 21% between 36 and 72 hours before death, and 13% greater than 72 hours before death. Often, the diagnosis of dying is difficult and made close to the time of death, in which patients cannot benefit from the end of life care preparation. Instead of attempting to improve the accuracy of diagnosing dying, it is more logical to promote systems where palliative care objectives are incorporated with ongoing care. Bereavement. Provisions of bereavement care is required as part of the Medicare hospice benefits. Bereavement support is available to family friends for a patient for 1 year, 1 month past anniversary of their death. This can take a form of psychological therapy or a follow up calls and visit to provide emotional support for those after the patient has passed. Progress in a palliative care. According to American Care of Serious Illnesses 2019 state by state report card on access to palliative care in our nation's hospitals, the US shows continued growth in the overall number of hospital palliative care teams. 72% of US hospitals with 50 or more beds report a palliative care team. This is up from 67% in 2015, 53% in 2008, and 7% in 2001. These hospitals currently serves 87% of all hospitalized patients in USA, yet the overall grade for US in 2019 is B, unchanged from 2015. Progress in end of life care. Studies have shown that approximately 80% of the Americans would prefer to die at home if possible. A minority of dying patients use hospice care, and even those patients are often referred to hospice only in the last 3 to 4 weeks of life. More recently, home has surpassed the hospital as the most common place of death in United States. Even though this seems like an improvement, this must be evaluated to ensure high quality end of life care is being provided. Care does not seem to be distributed according to need, but rather due factors like geographic location and whether a hospital is non or for profit. This is a diagram changes in the places of death in USA. Again, there's been a decline in the hospital death and a rise in the death at home. Nursing facility death rate remains the same. Progress in end of life care. Even though this seems like an improvement, this must be evaluated again to ensure that high quality care is provided. Palliative care in a COVID 19 pandemic. COVID 19 can progress rapidly, severely affected patients, and they are likely to lose their capacity to make decisions. It is appropriate to have a holistic urgent care plan in place in the event of acute deterioration. This plan should be implemented concurrently with an acute medical management plan in order to encompass anticipatory medications for symptom management as well as recognition of the patient's wishes and preferences. This discussion may need to had as early as when a first present to the hospital or seen in the community setting likely related to COVID-19 symptoms. Palliative care continued in a COVID 19 pandemic. If a patient lacks capacity to make their wishes known, exploring previously expressed preferences from those who know them well should be attempted. Circumstances of the pandemic further highlight the need and overall importance of incorporating palliative and end of life care practices within all aspects of medicine. The goal is to provide dignity in our patients' death. This is a quote by Dr. Dorothy Lay. Spiritual care lies at the heart of hospice. It says, "We are here. We will be with you in your living and your dying. We will free you from the pain and give you the freedom to find your own meaning in your own life, your way. We will comfort you and those you love, not always with words, often with touch or a glance. We will bring you hope, not for tomorrow, but for this day. We will not leave you. We will watch with you. We will be there." And now we have a post assessment test. Question is, hospice care provides comprehensive care, comfort care as well as support for the family while curative treatment are continued. Is it true or false? So the answer is false. Next question, palliative care and hospice care are the same. This is false again. And accepting hospice care means stopping all medical treatment. True or false? False. And question is, a palliative and hospice involves a team of both medical and non-medical provider. True or false? This is true. Hospice is covered by nearly all insurances. True. And a palliative care is care for those with life-limiting illnesses and their caretaker, with focus on symptoms control and quality of life. True. Thank you so much for listening to our presentation. My name is Saima Rashid. I'm a geriatric fellow physician at SUNY Downstate. Thank you so much.